This conference will now be recorded.
Okay, so today, as in the last week, you have discussed the anatomy and the physiology of the thyroid. Now we'll go ahead with the disorders of the thyroid. Actually, this is a very vast topic, but I'll be discussing only few points. So we'll just go through it. So it is classified based on the thyroid levels. Okay, so it can be a hypothyroid situation or a hyperthyroid situation. Hypo means the levels of the thyroid in the body is low. Means the T3, T4 are less, and the TSH will be more because to produce more T3 and T4, the hypothalamus will secrete thyrotropin releasing hormone, and that will act at the anterior pituitary and the thyroid stimulating hormone will be released, and that will again stimulate the thyroid follicles, which will with the process of oxidation organification of the iodine will transform into a T3 and T4. Okay, so when the levels of T3 and T4 are less and the TSH is more, it is known as hypothyroid condition. When the T3 and T4 are more and the thyroid levels TSH levels are very less, then it is known as hyperthyroid. Hypo means less T3 T4, hyper means more T3 T4. So these are the two. Based on these levels, we classify the thyroid disorders. So the most common condition generally we encounter in our OPDs are hypothyroidism. Okay, so generally we see most of the people in the hypothyroid symptoms. So it is the condition characterized by low levels of circulating thyroid hormone. So then again, hypothyroidism is again divided is classified as primary, transient, and secondary. So primary is due to causes like iodine deficiency. When you take low salt low iodine salt and all, then you'll have hypothyroidism. When there is congenital hypothyroidism, like there is no thyroid follicles in the body in the fetus, then due to the agenesis, there will be congenital hypothyroidism. Autoimmune conditions like Hashimoto's. This is one of the most common causes of hypothyroidism. Hashimoto's thyroiditis. Hydrogenic, like when we give the patients iodine 131 radioactive, iodine 131, or when we do a total thyroidectomy, when we do a external radiation, then the patients can have hypothyroidism. Drugs like some antithyroid drugs, interferon alpha, lithium, or para-aminosalicylate acid. So all these conditions will also cause hypothyroidism. Some infiltrative disorders like riddles, amyloidosis, sarcoidosis, these also will cause primary hypothyroidism. Transient is like in the case of postpartum, just immediately after the pregnancy, sometimes the patient, the ladies may have some postpartum hypothyroidism, but that will get resolved on its own. Subacute thyroiditis or withdrawal of thyroxine treatment. The patient is on thyroxine treatment and suddenly the patient has withdrawn it, then the patient might again go into hypothyroid situation. Or sometimes an excessive iodine. When the body has a very huge amount of iodine circulating in the blood levels, then due to the Wolff-Chaikoff effect, the patient can have hypothyroid. And what are the secondary conditions? When the hypopituitarism, like tumors of the pituitary or pituitary surgery when you do, or when you have trauma to the head, or Sheehan syndrome. So all these conditions will inhibit the production of thyroid stimulating hormone. That will again will have the T3 T4 decrease, and that will lead to hypothyroid. Isolated TSH deficiency or inactivity due to some of the enzymatic activities, TSH deficiency is there, then you can also have hypothyroid situation. Hypothalamic disorders like tumors, trauma, inferiority disorders, all apart means when the problem is with thyroid, you will have primary hypothyroidism. But the problem is at the pituitary level or hypothalamus level or due to some other conditions, then you will have, those are known as secondary. So this was the classification. Then what are the symptoms? Symptoms are the patient will be tired, they will be weak, the presence of dry skin, cold intolerance. You need to note down all this. Okay, so but to classify to differentiate between the symptoms of hypothyroid and hyperthyroid, you have to note it down. tiredness, weakness, dry skin, cold intolerance, constipation will be there, weight gain will be there, poor memory, menorrhagia, and dyspnea or hoarseness. So all these are the symptoms generally seen in the hypothyroid condition. Whereas the signs which we observe are dry coarse skin, as the patient will also complain of dry skin, and we will see that the skin is a much drier one. The patient will have a puffy face, hands and feet, edema will be there, diffuse alopecia, there will be hair loss, bradycardia, peripheral edema, delayed tendon reflex, carpal tunnel syndrome due to the compression of the ulnar nerve, and serious cavity effusion. So all these will be the signs seen in the hypothyroidism. Okay? So generally, in which conditions we get this hypothyroid? Mostly the body in the body the iodine levels are less. So the thyroid follicles get hypertrophied, so that more and more TSH is produced. The more and more TSH is need to be activated, right? So generally, the thyroid gland will get enlarged. So that is known as goiter. Goiter is in chronic enlargement of the thyroid gland, not due to neoplasm. Generally, when we have a cancer or a neoplasm, the gland enlarges. But if this is now due to the functional problem, there is no TSH in the body. The TSH levels are more, but there is no T3 and T4 levels in the body. So that's why the gland itself has hypertrophy or hyperplasia undergoes. What is an endemic goiter? Areas where more than 5% of the children, that is at the age of 6 to 12 years of age, have goiter. So when more than 5% of the children at this age group have a goiter, then it's known, and then that place is known as endemic. Sporadic is areas where less than 5% of the children have goiter, and multinodal goiter in sporadic areas often denotes the presence of multiple nodules rather than gross gland enlargement. So, in the sporadic areas, what happens is there are multiple nodules. As you know, there are various follicles, follicles in the thyroid. Only some follicles get hypertrophied. So, the patient will have multinodular goiter. So endemic is more than 5% of the children, sporadic is less than 5% of the children. And what are the most common etiologies? Hashimoto's. Hashimoto's thyroiditis is one of the most common etiology in the hypothyroid. Graves' disease. Just remember the subheadings. No need to go into all this. Hypothyroid means less T3 and T4, more of TSH, and goiter is one of the most common. And in the goiter, most common etiology is Hashimoto's, then Graves' disease, died due to some goitrogenic foods like cabbage, turnips, cauliflower, broccoli. These also cause hypothyroid condition. When there is chronic iodine excess, like in Wolff-Chaikoff effect, you will also have this. And some medications like lithium, they will prevent the release of hormone, which causes 6% of goiter. So etiology is Hashimoto's, Graves, diet, chronic iodine excess, and medications. What is the pathogenesis? Generally, when iodine deficient areas, there is iodine deficiency is there. So less number in the blood levels, there is no iodine to be extracted into the thyroid. So TSH is more and more. TSH increases. And in iodine replete areas, generally the thyroid follicles are heterogeneous in their growth and activity, and mostly they will have multiple MNG, multiple nodular goiter. Okay, so pathogenesis can be classified as iodine deficient areas and iodine replete areas. How do you evaluate? We do a TSH, T4, T3. Then what is overt hyperthyroidism? See, generally in the hypothyroidism, TSH will be high, T4 will be low, T3 will be low. But what is overt hyperthyroidism? TSH will be low and T4, T3 will be high. And subclinical hyperthyroidism is TSH is very low and T3, T4 are normal. When the T3, T4 are normal and TSH is low, it is known as subclinical. When it is called as hyper, when the TSH is low and T4, T3 are high. If the T4, T3 are low and TSH is high, then it is hypothyroidism. So when the patient comes to with a goiter, we do a thyroid function test, and according to the levels of this T3, T4, TSH, we classify them as hyperthyroidism or subclinical hyperthyroidism. So determination of the thyroid state is key in determining treatment. The treatment will be according to the thyroid levels. So this is a condition of a diffused colloid goiter. Okay, this is a diffuse. You can see this is the thyroid gland which is stored on both the side. It has it's a butterfly shaped gland. Okay, so you can see this is the butterfly shaped gland, and there is the diffuse enlargement disease. That's why we will call it as a diffused colloid goiter. Whereas this is a multinodular, you can see this nodule has a very large size. This is a very, comparatively small size. So this is a multinodular goiter. This is a diffuse and this is a multinodular goiter. Then coming to the hyperthyroidism, it is due to the result of excessive thyroid function. That TSH is low and T3 T4 are more. Okay. And what is thyrotoxicosis? It is the state of thyroid hormone excess. So the condition where the thyroid hormone is excess is known as thyrotoxicosis. Due to the thyrotoxicosis, the hyperthyroidism occurs. Okay, you need to understand this terminology. Thyrotoxicosis is the state of excessive thyroid hormone, and what happens due to thyrotoxicosis? Hyperthyroidism occurs. So again, it is also classified as primary and secondary. Primary is due to the thyroid pathology. It can be seen in the graves. In hypo, we had Hashimoto's, so that is the most common. But in hyperthyroidism, the most common is Graves. It can also be due to a toxic multinodular goiter or toxic adenoma. Toxic is due to they will have some symptoms. They they will have fever and all. They will have some fever symptoms or some hoarseness or some systemic symptoms will be there. That is why it is not as toxic. Multinodular goiter in general is a hypothyroid condition, but when due to excessive thyroid hormone, it turns into toxic and it is a cause of hyperthyroidism. Functioning thyroid carcinoma mets, mutation of TSH receptor, stroma ovari, and drugs can also cause iodine excess. So these are some of the conditions of primary. Whereas the secondary is TSH secreting pituitary adenoma, chorionic gonadotropin secreting tumors, gestational thyrotoxicosis. So these are some of the conditions where TSH is less. Thyrotoxicosis without hyperthyroidism. So sometimes hyperthyroidism also occurs without this thyrotoxicosis. What are that conditions? Subacute thyroiditis, silent thyroiditis, and ingestion of excessive thyroid hormone. If the patient we asked to take around 50 mg thyroxine, but the patient is taking 150 mg, so then the patient will have hyperthyroidism, but they won't have any thyrotoxicosis. Okay. So these are some of the conditions where hyperthyroidism manifests without thyrotoxicosis. So what are the symptoms? See, the opposite of the hypothyroidism will happen. The patient had cold intolerance there. Here, the patient will have heat intolerance. The patient will have excessive sweating. The palpitations will be there. Weight loss. There, the patient used to have weight gain. Here, weight loss. Diarrhea will be there. In hypo had constipation. Tremorlessness or jitteriness will be seen in the hyperthyroid, menstrual irregularities, nervousness, eye symptoms will be there in this hyperthyroid. The signs are tachycardia. We had bradycardia there, we will have tachycardia here. Tremor will be there, the patient will have goiter. There, the patient had a dry skin. We'll see some warm skin due to the excessive sweating. Muscle wasting will be there, eye signs, gynecomastia, and insomnia. So all these signs will be seen in hyperthyroid. So ophthalmopathy and dermopathy are generally seen in Graves. So in Graves disease, you will be seeing ophthalmopathy, that is eye signs, and dermopathy. The skin changes are generally more commonly seen in Graves disease. Okay, they are more specifically seen in Graves. Then what is thyroiditis? The term thyroiditis encompasses many relatively common inflammatory thyroid disorders. It is the inflammation of the thyroid gland. Okay, it is the inflammation of the thyroid gland. There are many terminologies which you might get confused, but just remember this few terms. That's it. Thyrotoxicosis, painless sporadic thyroiditis, painless postpartum thyroiditis, painful subacute thyroiditis, superthyroid. We will be discussing a bit of these also. So these will cause transient thyrotoxicosis. What is thyrotoxicosis? Excessive thyroid hormone. Okay. So all these conditions will cause transient thyrotoxicosis. The first biochemical change in inflammatory thyroiditis before the onset of thyrotoxicosis is an increase in the serum concentration of thyroglobulin. Thyroglobulin is a protein which used to carry MIT, DIT, and all the iodine, okay, into the thyroid lumen. So first, what happens when the patient is having thyroiditis is there will be increased concentration of the thyroglobulin, and the patient will have increased T3 T4 and the patient will have reduced TSH. So this is the biochemical change which happens. The signs and symptoms of thyrotoxicosis due to thyroiditis are usually not severe, and the patient can also have a hypothyroid stage also, okay, due to the depletion of stored thyroid hormones. So subclinical hypothyroidism is normal free T3 and T4, but the levels of TSH will be more. So subclinical hypothyroidism or mild thyroid failure, it is a combination of elevated serum thyrotropin concentration and normal free T3 and T4. What is overt hypothyroidism? It is the combination of elevated thyrotropin concentration and low T4. When you only have low T4 with elevated TSH, it is overt hypothyroidism. When you have normal free T3 and T4 but increased TSH, it is known as subclinical hypothyroidism. Once the serum T3 concentration falls below the normal level, the classical symptoms of and signs of hypothyroidism occur. Once the T3 levels decrease, the patient will have hypothyroid. So all thyroiditis will ultimately be hypothyroid. Initially, if the thyroiditis patients may show hyperthyroidism feature, but ultimately everyone will have hypothyroidism because there is an acute inflammation is there, and the DSH will have to be gradually increased, and the T34 will gradually decrease. So what are the types of thyroiditis? Hashimoto's, painless postpartum, painless sporadic, painless subacute, suppurative, drug-induced riddles. So these are some of the thyroiditis conditions. Initially, they might show some hyperthyroid features, but ultimately all will become hypothyroid. Okay. Briefly, Hashimoto's, it is the most common type, and clinically, the patient can have firm swelling or nodular swelling, symmetric in size, and painless goiter will be there. And about 10% they might have atrophic thyroid glands also. When you do investigations, the high serum thyroid antibody concentration will be there. There will be high serum thyroid antibody concentration, and the high serum thyroid peroxidase antibody concentration will be there. Increased serum thyroglobulin. Ultrasound will show hypoechogenic, and FNAC is to be done to rule out lymphoma and thyroid carcinoma. So what are the investigations done? You will do a thyroid antibody concentration, which will be, as this is the autoimmune condition, the antibodies will be more. Thyroid peroxidase antibody concentration will be high. Thyroglobulin will be high. So all this will cause TSH to be produced more, and T3 T4 as the T3 T4 is very less in Hashimoto's, the TSH is produced more and more and more. So that will increase the levels of T3 and T4, and the patient will become euthyroid. So what is painless postpartum? It is generally seen few months after delivery. Thyrotoxicosis typically begins 1 to 6 months after delivery and lasts for about 1 to 2 months. And that phase is followed by a hypothyroid phase. 80% of the women recover normal thyroid function within a year, and permanent hypothyroidism is also seen in 50% of the women. So it is generally seen after first few months of the delivery. Generally, the thyrotoxicosis will be seen in 1 to 6 months later. The phase of hypothyroid will start, and 80% will recover in 1 year, and 50% may have chances to have permanent hypothyroidism. Clinically, the swellings are small, non-tender, firm, and lab investigations. You have high serum TPO antibodies, thyroid peroxidase antibodies, high serum concentration of thyroglobulin, that is TSH, and 24-hour iodine 123 uptake will be more, and 70% will have chances of recurrence in subsequent pregnancies. Painless sporadic. The only exception is, before pregnancy, the painless postpartum thyroiditis and they cannot be distinguished, except that postpartum is generally seen after pregnancy. All the features of the same are the same. Painful subacute. So we had seen painless postpartum and painless sporadic. Now the painful subacute. It is a self-limited inflammatory disorder and is the most common cause of thyroid pain. When the patient comes with neck pain and you suspect there is a thyroid swelling and it is painful, then the most common condition is painful subacute thyroiditis. It occurs in 5% of the patients with clinically thyroid disease. Generally follows a viral infection post URTI. The patient will have myalgias, pharyngitis, low-grade fever, fatigue, and up to 50% the patients may have symptoms of thyrotoxicosis. But ultimately, the hypothyroidism will occur after 4 to 6 months. So, lab investigations. As this is an inflammatory condition, there will be elevated ISR, elevated CRP, elevated total leukocyte count, and the peripheral blood thyroid hormone concentrations are elevated. Serum TPO antibodies will be normal, as this is not an autoimmune condition. This will be normal, and the 24-hour iodine 123 uptake will be low. So it's a more of a inflammatory condition, not a thyroid condition. Then what is suppurative? When there is some bacterial infection along with the viral infection or along with the thyroid disorder, it is known as suppurative. Caused by bacterial infection, but fungal mycobacterial are also can be seen. The thyroid is resistant to infection because of its encapsulation. As we have seen, the thyroid is have a surgical capsule, right? So it is generally resistant to infection because of encapsulation, high iodine content, rich blood supply, and extensive lymphatic drainage. And suppurative iodine is therefore very rarely seen. So it is most likely to occur in patients with pre-existing thyroid disease, congenital anomalies, or immunosuppressant, or elderly people. So suppression means due to bacterial infection, generally rare due to encapsulation, high iodine content, rich blood supply, and extensive lymphatic drainage. Patients are acutely ill with fever. Toxic symptoms will be there due to bacterial infection. Fever, dysphagia, dysphonia, anterior neck pain, erythema. So thyroid function will be normal, elevated leukocyte count, elevated ESR, and when you do a radioactive scanning, you will get cold nodules. And FNAC is generally done with gram staining and culture to rule out bacterial infection. When the patient comes to you with thyroid neck pain and you suspect thyroiditis, so if you do an FNAC and gram staining in culture, if you find out any bacterial infection, if you also and if you give the antibiotic, particular antibiotic according to the culture, the patient will have symptoms relieved. Because the thyroid function is normal, only the inflammation has to be decreased. So when you do this investigation, you will get the treatment done. Drug-induced thyroiditis, like amiodarone, lithium, interferon alpha, interleukin 2, so all these conditions will give inflammatory thyroiditis. Lithium is one of the cause. So the lithium thyrotoxicosis has been reported after long-term lithium use. So what lithium does is it affects the thyroid cells. Okay, it affects the thyroid cells. Interferon alpha, interleukin 2. So all these were. So these are those were drug induced. And the last one is Riddle's thyroiditis. That is fibrous type. It is a fibrotic process. Okay, local manifestation of systemic fibrotic process. The progressive fibrosis of the thyroid gland that may extend to surrounding tissue, and the cause is unknown, and high serum thyroid antibody concentration are present in 67% of the cases. So when there is systemic fibrotic process, then it is known as Riddle's. Symptoms will be it will be rock hard, fixed, and painless goiter. The patient will have dyspnea due to tracheal compression, dysphagia due to esophageal compression, as it is rock hard. Hypoparathyroidism can be seen. Most patients are euthyroid to hypothyroid, and a nephritic diagnosis is made by open biopsy. When you do a biopsy, you will see the excessive fibrous tissue in the thyroid gland, and that itself will diagnose the renal thyroiditis. So this was up till all the thyroid conditions. Now we will go to thyroid malignancy. Thyroid malignancy is around 1.5% of all the cancers, and most common is papillary, followed by follicular, followed by medullary, and the last is anaplastic, which is very lethal, and the patient's prognosis is very poor, and the 5-year survival is less than 2 years. Okay, I mean, less than 10%. So what are the predisposing factors for thyroid cancer? Prolonged stimulation by elevated TSH. So any hypothyroid condition can cause hypothyroid cancer. If the patient is not clear, is not treated well, and due to excessive stimulation of TSH, then the patient can have thyroid cancer. So that's why when the patients come with multinodular goiter, we generally take out the thyroid and we give them the thyroid supplements. Solitary thyroid nodule can also turn into thyroid cancer. Ionizing radiation, genetic factors, chronic lymphocytic thyroiditis, all these are the predisposing factors for thyroid cancer. What are the etiologies? Genetic basis like red proton gene or or some mutations of these enzymes or something will cause thyroid cancer due to radiation, due to family history, due to pre-existing thyroid disease. All these can be are the etiologic factors for thyroid cancer. So nodules more likely to be malignant if the patient has positive family history, previous history of thyroid carcinoma, or the nodule is enlarging. In spite of giving treatments, if it's an enlarging nodule, then it can also cause malignant. It can turn into malignant. Less than 14 and more than 65 years of age have more chances of malignant transformation. Male patients, generally thyroid are most commonly seen in females. If that is seen in male patient, then the nodules can be malignant. Past history of ionizing radiation, elevated TSH, positive thyroid antibody, all these can give you a conclusion that that can be a malignant disease. What are the clinical manifestations? The patient can have a solitary thyroid nodule. The patient will definitely have cervical lymphadenopathy due to extensive lymphatic drainage of the thyroid. Rapidly enlarging goiter is also a symptom. Pain in the neck. Generally, pain in the neck is only seen in the conditions of malignancy and thyroiditis. Okay, local symptoms like dysphagia and dyspnea, portions of voice, or nodal and distal metastasis. All these will give you a of thyroid cancer. Papillary, most common seen. These are the following histological subtypes. Females are more common to get the prognosis is papillary carcinoma, and the mean age is 40 years. Okay, so this is the pathogenesis. No need to remember. Lymphatic lymph node involvement is common. The presentation is asymptomatic thyroid nodule discovered by FNAC generally. FNAP. Advanced disease will have hoarseness, dysphagia. Hoarseness is due to the involvement of thyroid cartilage. Dysphagia is due to the involvement of esophagus. Cough or dyspnea will be seen there generally. And sometimes the lung metastasis is also seen in the conditions of papillary. Microcarcinomas is generally a manifestation of papillary carcinoma. Means the papillary carcinomas are more smaller than 1 centimeter. So you have microcarcinomas in papillary carcinoma. Pathology often multifocal and unencapsulated. It's not capsulated. Okay. The capsule means the cancer will come out of the capsule. The patients will have some bodies when done histology and orphan annie cells. Orphan annie cells and some bodies are characteristic of papillary carcinoma. So whenever a question is asked, the sum of bodies are seen in, then the only answer should be a papillary carcinoma thyroid. Okay. Coming to the follicular, it is seen in 20%. Women are more prognosis 60%. Metastasis is general. Mean age is 39 years. generally seen due to angioinvasion and hematogenous spread, and lymphatic involvement is in 13%. So more frequency than papillary cancer in iodine deficiency area. Iodine deficient areas, more chances of follicular than papillary. Pathology is this is encapsulated. Follicular carcinoma is encapsulated. Papillary was unencapsulated, and generally it's a solitary one. Histology, it is very well differentiated, and FNAC and frozen section cannot distinguish between a benign and malignant condition, as the capsule is not invaded. Urethral cell carcinoma is also one of the variant, one of the type of malignancy. Women are more commonly affected, 4 to 10% of thyroid malignancies, and carcinoma requires evidence of vascular and capsular invasion. Lymphatic spread is seen, distant metastasis is seen. So 75% of the urethral cell component. Anaplastic acid, highly lethal form of thyroid cancer. Median survival is less than 8 months, and 1 to 10% of all the thyroid cancers affects the elderly. Mean age is 60 years. 53% have benign thyroid disease, and death will be there. Mostly less than 1 year, the patient will die definitely. So medullary, the last thyroid carcinoma, which arises from the parafollicular cells or the C cells of the thyroid gland. So there will be some calcium problem because C cells will secrete calcitonin, and that is important for the calcium homeostasis, right? So there will be hypocalcemia in these patients. It has 4 subclinical types: MEN1 and MEN2, and familial and sporadic type. Sporadic is most common of the medullary thyroid carcinomas. Mean age is 50 years. It is unilateral and unifocal and slightly more aggressive than and MEN2A. Familial is generally autosomal dominant type. It is multifocal and bilateral, and 100% 15. It has very thyroid medullary thyroid carcinomas. Men best prognosis among all the one. MEN2A is known as sickle syndrome. MEN2B is known as Vermus syndrome type, and this is the most aggressive. 100 the patients will have a we will have thyroid, pheochromocytoma, parathyroid, whereas the men pheochromocytoma, multiple mucosal neuromas, and marfanite body hair. Diagnosis is done by serum calcium 24 hours, urinary catecholamines, basal stimulated serum calcium levels, CEA. So all these are the investigations which you need to do to diagnose medullary thyroid carcinoma. FNAC is done. Thyroid lymphomas are very uncommon, less than 5%. Clinically presentation variable, commonly expanding nodules. Histopathologic, plastic, and prognosis excellent. So staging, no need to remember. As thyroid will be taught to you in general surgery in a extensive way. I have just taken you, I have just told you the conditions, the names of it, and some of the symptoms and signs. Okay, so I'll share this PPT also with you. If you want to just go through this, once you go through, thyroid won't be asked you much. You won't have any cases in your practicals, and only few questions, like a short question can be asked in thyroid. So don't go into much deep. Thyroid is generally taught to you in surgery. The thyroidectomy, I'll just briefly tell in the next class. Okay. If anyone has any doubts, you can unmute yourself and ask, or else I will just stop this class and share this PPT with you. Okay, then thank you so much.